Now let's see about endocrine system. So under endocrine system, we'll just be seeing about the thyroid cancers, which can be as image based questions, and other than that, Men's syndrome alone. So thyroid cancers, the most common thyroid cancer will be the papillary carcinoma of thyroid. Usually, it is going to affect young adults of 20 to 40 years of age group, and here it is associated with radiation. Okay, for some other reason, or some other tumor, suppose a lymphoma, the patient is having some lymphoma, they had given some radiation therapy, or some oral cancer, they are giving some radiation therapy. Because of the radiation exposure, the patient can develop a thyroid malignancy, which is going to be of the papillary carcinoma type. The genetics of papillary carcinoma is very important because it is kind of specific. So we'll have a BRAF mutation. So BRAF mutations can be seen in many cancers. So papillary carcinoma of thyroid is one such in which BRAF mutation is present. Other than that, we can have RET PTC rearrangements. Okay, RET PTC rearrangements, and then tyrosine kinase NTRK rearrangements. So all of this can be seen in papillary carcinoma of thyroid. So the various morphological variants of papillary carcinoma are, there are about 10 to 12, and here the most common one of which will be the follicular variant of PTC. So we represent it as FVPTC. So FVPTC is the most common one. Herein the arrangement of the thyroid epithelial cells will be like follicles only, back-to-back arrangement of follicles will be there, but still the nuclear features of papillary carcinoma of thyroid is going to be present. Other than that, we have the classical morphology, which has the papillae, and then we have the tall cell morphology or diffuse sclerosing morphology. So other than that, we are going to have the tall cell and the diffuse sclerosing morphology. So both the tall cell morphology and diffuse sclerosing morphology are going to be associated with worse prognosis. As such, papillary carcinoma of thyroid is associated with excellent prognosis, while these two variants are associated with worse prognosis. And PTC is associated with lymphatic spread. So they'll present with cervical lymphadenopathy usually. So spread of mode of metastasis will be lymphatic. So the image based questions about papillary carcinoma will be important. So let us see. So in this, if you see, these are all forming small papillae. So this is a fibrovascular core, and here it is forming this finger-like projection. Inside also you are having this fibrovascular core. So all of these are also papillae only, but it is cut like this. So cross cut section of this papillae is appearing like this. So here we have this blood vessels. So blood vessel core is present. Same thing on the next image also. Here also you can see the cut section of this papillae. So inside we are having this blood vessel, which is this is the polypoidal structure around it. So these papillae are going to be lined by the thyroid follicular cells, and the most important thing about this will be the nuclear features. So before that, since it is a papillary kind of feature, so we are going to see Samoma bodies. So all of these are Samoma bodies which are laminated calcification. So any papillary tumor is going to have Samoma body. So the nuclear features of PTC is the one which defines a PTC. Unless you see the nuclear features, even if it shows papillary kind of architecture, you are not supposed to label it as PTC. So what are the nuclear features which define PTC? Firstly, there will be clearing of the nucleus. So optically clear nucleus will be present. Then you have nuclear enlargement. Then you have nuclear overlapping. Then the presence of nuclear pseudo inclusions and nuclear grooving. So these are all these features represent the classical features of PTC. So this image, first image is that of a orphan nucleus, which we also called as a optically clear nucleus. So all of this nucleus is appearing as if they are empty, right? This is because the chromatin has all moved into the peripheral margins. So they appear as if they are clear. This is actually a tissue artifact, and only on histological sections you see this kind of optically clear nucleus. Why is it given this name of orphan nucleus? Because it resembles this cartoon character here. So her eyes is all looking optically clear, right? So that is why it is called as a orphan nucleus. So in the second image, if you see, this is a intranuclear inclusions. So but this inclusion is actually a pseudo inclusion because it is the cytoplasm which has gone into the nucleus and formed an inclusion. So if you match the cytoplasm color with that of this inclusion, it will be the same. So this kind of inclusions are called as nuclear pseudo inclusions. Then we can have this presence of these nuclear grooves. So nuclear grooves are again features of PTC. So the nuclear groove is going to be perpendicular to the cell like this. Like sorry, not perpendicular, it is going to be transverse. So this is the maximum diameter, so this nucleus groove should be like this. So if the cell is like this, if it is if I see a groove like this, this is not a nuclear groove. So the defining feature will be, it should be along the long axis of the cell. So the groove should be on the long axis of the cell. So nuclear grooves are seen, and here if you appreciate, there is nuclear overlapping and nuclear crowding. So as such, the nucleus is also enlarged compared to a normal thyroid follicular cell. So we see nuclear enlargement, then we see nuclear pseudo-inclusions, then nuclear grooving, then this optically clear nucleus or peripheral chromatin condensation, along with that nuclear overlapping also. Okay, all of these features define PTC. So when I mentioned this optically clear nucleus, I told this is only seen in histological sections. While on cytology, if you see a papillary thyroid carcinoma, it is not going to appear optically clear. It is going to show a different kind of chromatin only. Okay, so it will not be optically clear. The next carcinoma is follicular carcinoma of thyroid. Here the origin is again from the follicular cells only, and here this will be associated with multinodular goiter. PTC was associated with radiation exposure, while multinodular goiter is associated with follicular carcinoma. So here the mutations again are KRAS mutations, PIK3AKT pathway, which is the major pathway. So AKT pathway is being mutated, and we also can have PPAR gamma rearrangements. So these kind of specific mutations are seen in follicular carcinoma of thyroid. And the most important feature histologically also to call it as a follicular carcinoma is only when you see a capsular and or a vascular invasion. So only when you see capsular or vascular invasion, you can call it as a follicular carcinoma. Otherwise, it will be labeled as a follicular adenoma only. Okay, because both of it is going to appear the same. Follicular pattern of this thyroid epithelial cells will be there, and they will be forming back-to-back follicles. So unless there is invasion, you cannot call it as a carcinoma. So this is the reason why you cannot distinguish between a follicular adenoma and a carcinoma on cytology. So when you do FNAC, you cannot sample the entire capsule or the vessels, right? So you cannot detect the capsular or vascular invasion. So this is very important. FNAC cannot distinguish between follicular adenoma from a follicular thyroid carcinoma. And here the metastasis of mode of metastasis of follicular thyroid carcinoma is going to be hematogenous, and it will spread to the bone usually. Okay, so bone metastasis, while PTC was to lymphatic spread through the cervical lymph nodes.